Good evening. This evening we are going to go over a proposal to make accurate medication lists across the continuum of care. Our objectives for this evening are to review the problem, the framework of innovation, evaluation of the research that was completed, solutions proposed, and the goals of the solution, and lastly, the elevator pitch. Review of the problem. The medication list in our electronic health record is one list across multiple practices. This means there are providers within each practice, whether that's a physician or a mid-level APP, advanced practice provider, that wants the medication list reviewed their way. So there's multiple things happening within the practices that aren't consistent across the board. There's also a feature called Care Everywhere, which brings in medications from organizations not on the same electronic health record. The issue with this is that it does not pull all of the same information, plus it could be an old medication that's pulling into the list that's not accurate. Patients aren't sure what medications they're taking. There's duplicate medications on the list, and with the electronic health record we currently have at Lancaster General, there are expired medications on the list, and people are unsure how to remove them due to how they are on the med list. Framework of innovation, there's cost and quality implications here. So with cost, we have a lot of rework being completed at all encounters, even some in the same day. The nurse or clinical staff is going in and reviewing the medication list, and the provider not sure of what all they reviewed, even though there is a mark as a review button. It's not intuitive of what all they reviewed. It basically just saying that they clicked a button. So the provider redoes a medication list review with the patient. Patients admitted are potentially getting wrong medications due to the list not being accurate, and while the cost of medication might be small, the cost of the error to the patient could be significant. Quality, there's confusion within the office staff on what medications are appropriate to be on the list. So by having an accurate med list or an accurate or a standard of process for updating the med list, it would decrease this confusion. And also, back to the inpatient side as well, the inpatient admissions would go quicker if the list is accurate and that we know that the list has been updated recently. Basically, with the research that we found, or that I found, was that there's no good way to do things. Getting a lot of providers on board to do things the same way within their staff can be very tricky. But that everyone is basically trying to keep their heads above water within their own respective EHR. Because there are multiple ways to do things, and getting multiple staff and provider on board, they're basically just doing what they need to do to make sure that their work is done. There is not a lot of research on the best way to do an accurate med list across the continuum of care. I checked the advisory board and the Agency for Healthcare Research and Quality. Now, the Agency for Healthcare Research and Quality did have that document that's referenced there, Medications at Transition and Clinical Handoff, which is the MATCH toolkit for medication reconciliation. It's a 96-page document on a project to how to basically revamp including build within your EHR. The problem with this is we don't have time for a project. The medication list issue needs to be resolved today. Actually, it needs to be resolved yesterday. So we don't have time to set up a project and get key stakeholders. We need something that we can implement today. And we also checked Google, and Googling there's not a lot of things on Google and EBSCOhost related to ways to ensure that your medication list is accurate. Solution proposed. The solution we're proposing is to embed specialized trained staff in the ambulatory practices as well as the inpatient setting. We're going to equip them with standards that are agreed upon within the organization, so that way they can complete this review of medications based off of these standards. And during the downtime within the practice and the inpatient setting, these specialized staff would call patients that have upcoming appointments or upcoming procedures and start to review their medication list with them over the phone, also asking them to bring in their pill bottles when they come in for their visit or procedure. Our goal is to embed the staff within the practice to review this medication list. We also want to try and change the patient's mindset to have them start to bring all their pill bottles with them to all ambulatory and inpatient visits. This is something that we have them do occasionally when they're discharged from home health or from a long-term care facility. We'll ask them to bring this stuff in, but it's never consistent. So one time they might bring it and they might not bring it back for 6 months to a year. So having them bring their medication pill bottles each time would be a huge significant help to this. And we also want to decrease provider confusion on if and when the medication list has last had a comprehensive review. So the elevator pitch. Want to ensure that a comprehensive medication reconciliation is completed at each face-to-face encounter. Medication reconciliation across the continuum of care is a thorn in providers' side due to every practice and/or provider completed this task differently. It is difficult for providers to determine when a comprehensive medication reconciliation was last completed. Embedding specially trained staff in the ambulatory practices as well as inpatient setting would ensure that a comprehensive medication reconciliation is completed at each face-to-face encounter, decreasing provider and staff confusion. Want to see this happen in your clinical setting? Talk to your provider today. Any questions? Thank you.